MCQs of medicine. I know the questions are a bit lengthy, but these are actually the questions which they are asking nowadays in exams. So there are some numericals, but I want you to solve these questions in one line. Try to make your diagnosis, then try to rule out other options, and only you can have a nice approach in solving these questions. So I know there will be questions little complex and long compared to other subject, but this is medicine. You will have definitely some cases in exam. So starting with the first question on ABG. So let's see. 58-year-old. So first age is the age itself. Obese lady. Present to emergency room with complaint of difficulty breathing for last 2 days. So last 2 days. So I can say there is more chance of an acute process, but it is not always true, because maybe it could be like an acute or chronic illness. She has become drowsy, but arousable on loud voice command. It means she is having a low GCS. Oxygen saturation is 82%. Bilateral polyphonic rhonchi on auscultation. She has been on regular medication for diabetes and coronary artery disease for the last 10 years. She started on oxygen therapy along with supportive treatment. ABG is given below. So, I told you before in our app also, like if pH and PCO2, they move in same direction. So, same is having M, then disorder is metabolic. And if pH and PCO2, they move in reverse direction, then disorder is respiratory. So just look at the question carefully. pH is a decrease. So if you see, the normal value of pH will be 7.35 to 7.45, and normal value of PaCO2, it is 35 to 45. And normal value of bicarbonate is also important, so that will be in the range of 22 to 26. So I can take an average of 24. So let's see, pH is reduced and PaCO2 is increased. So you can see directions are reversed. So disorder is respiratory. And when we say disorder is respiratory, now look at the pH is reduced. When pH is reduced and PaCO2 is increased, it means this is pH low, means it's a case of acidosis. So it's a case of respiratory acidosis. Now see, these two options are ruled out: metabolic acidosis and alkalosis. Now we need to check whether it is acute respiratory acidosis with compensation or without compensation. So understand this. When bicarbonate value is more, it means kidneys are doing some sort of compensation. It means kidneys are trying to release bicarbonate. So normal it should be less than 26. But when it is increased, it means kidneys are trying. So it is definitely a case of some sort of compensation or metabolic alkalosis compensation through kidney. But to prove this, understand this. To prove this, what I can say, for every 10 mm, so I can say for every 10 increase in PaCO2, bicarbonate will increase by 1 if it's an acute process, in case of acute process. And for every 10 increase in PaCO2, bicarbonate will increase by 4 in case of chronic. Now just try to understand this. Suppose I can say, let me write here PaCO2 and bicarbonate. So what I told you here, for every, suppose if it is an acute condition, in acute condition, for every 10, it is bicarbonate increase by 1, and in case of chronic, for every 10, bicarbonate will increase by 4. Now let us see what is happening in our case. PaCO2 value, what I told you, PaCO2 in the range of normal value is 35 to 45. And what is given in this question? In this question, PaCO2 is given 76. So if I say like 45 to be the like I can say maximal value, so for 55, 65, 75. So 75 plus 1, 76. So 31 is the change or increase in PaCO2. So let me say 30 is the change in PaCO2. Now tell me, if it is an acute process, and if PaCO2 is increasing, is becoming 30, So I told you for every 10 it's 1. It means then this will be increased by 3. And if it is, I can say chronic process, then bicarbonate should increase by 12. Clear? Now, if you see like bicarbonate in my patient, bicarbonate is 26, and it's 26. If you add 12, this will become huge. But if you add 3, this will become 29. 29, which is approximately, or I can say, which is close to 33. So it's a case of, I can say again, we don't have to make a comment on acute or chronic here, but sometimes they ask you. So it is a case of acute respiratory acidosis. Since bicarbonates are increasing, so there is some sort of metabolic compensation by kidney. Clear? And when you can see like when pH is not fully normal, so it is not fully compensated. It's again a partial compensated. So let us see one more question. For your practice, you will get an idea. So 70-year-old male chronic smoker, known diabetic and hypertensive, presented to emergency room with complaint of breathing difficulty for 2 days. Again, 2 days, then there is a more chance of acute illness. Worsened since 1 day with altered sensorium, labored breathing pattern. On examination, BP is 130/90, which is quite normal. Heart rate is 120, slightly increased. Saturation of 80%. This is important. Oxygen saturation is less. Respiratory is 36. ABG is having pH 7.2. So let me write here pH. What is important for us? pH is 7.2. So I can put an arrow on downside. Then I can say PaCO2 value. PaCO2 value is 80. So normal value of pH is 7.35 to 7.45. Right? And if you see like PaCO2 normal value is 35 to 45. So PaCO2, I can say it is increased. PaCO2 is increased. So you can see the direction is reverse and pH is decreased. So again, this is also respiratory acidosis. So when I say respiratory acidosis, so I can say these options are ruled out. Now we need to check in this question whether it is acute or chronic. So that's why I was explaining the same thing to you. So I told you like for every 10 increase in PaCO2, bicarbonate will increase by 1 when it's an acute process. So ratio is 10:1. And in case of a chronic, for every 10, bicarbonate will increase by 4 in case of chronic process. So that is something which you have to remember, because here we need to apply this. So let us make again same thing which I am doing here. So I am writing here PaCO2 value, and here I am writing bicarbonate value. So if you see PaCO2 value, suppose let me say it is an acute process. Let us see it's an acute process. So PaCO2 is how much? PaCO2 is given 80. So let's say on an average 40 is normal. So 40 is increased. 40 is increased means it is increased by 40. Then in case of acute process, bicarbonate shall increase by 4. So let me say normal bicarbonate is 22 to 26. So if I take the maximum at 26, you will add 4. This will become 30. And if I say it's a chronic process, when there is increase by 40, it means there should be increase by so for every 10 it is 4. So every 40 it will be 16. There will be increase by 16. Now if you add 26 plus 16, this will become 42. So in this case, if you see, bicarbonate is given 30. So bicarbonate which we calculated, that's also coming 30. So again, it's a case of acute illness. So it's a case of acute respiratory acidosis. Clear? So this is that's why it's important to calculate this, because sometimes they can ask you to differentiate acute or chronic. So above, like if in previous question, you can see this was very simple. So we are just you can see bicarbonate, you can see kidneys are working. Here also you can see bicarbonate is increased. So here also I can say bicarbonates are increased when kidneys are working. So it's also having some sort of metabolic alkalosis. Coming to next question, a 45-year-old chronic alcoholic. So let's see this. 45-year-old chronic alcoholic comes to OPD complaint of anorexia, nausea, vomiting, and yellowish discoloration of skin and urine for 3 weeks. So lab parameters are bilirubin 7. Bilirubin is very high, very, very important. Then direct fraction is 5, AST is 280, ALT is 135. So I made a diagnosis. You can see AST value is more than ALT. If you calculate the ratio, this will come 135, 135, 135. Little bit of mathematics. I know doctors are weak in mathematics. 135, 135, 270. It is coming 280. So more than 2:1. So since I can say how I will make a diagnosis, you can notice there is history of alcohol. Then you can see patient is having jaundice. The patient is having jaundice. Then you can notice AST-ALT ratio. If I calculate this, 280 divided by 135, let me say, to make it simple, 140 into 2, 280. So it is coming more than 2:1. So this is suggestive of alcoholic hepatitis. So diagnosis I made, bilirubin is increased. That's why patient is having jaundice. So diagnosis alcoholic hepatitis. Now PT is given. So see, PT is 20, INR is 1.4, PTC is corrected PT, that is 16. Ultrasound is having grade 2 fatty liver, so it is again, it could be due to alcoholic fatty liver and mild ascites. Which of the following is correct statement? Okay, so basically it's a case of alcoholic hepatitis. So let me make a diagnosis. It is alcoholic hepatitis, and I told you for alcoholic hepatitis how we manage. We calculate either Madri's discriminant factor, we call this MDF, and when Madrid discriminant factor value is more than 32 or a MELD score value is more than 21, in these cases we will start steroid. And when we start steroid, like you can see, like a dramatic improvement. So it is the drug of choice. So drug of choice will be steroid. Otherwise we can use pentoxifylline for symptomatic relief. So MELD score, if you see, for MELD score calculation we need creatinine, bilirubin, INR. So patient INR is given, bilirubin is given, creatinine is not given. So basically they are asking you, like let's see the option. Steroids are indicated in this case after ruling out varicose bleed and sepsis along with alcohol cessation. So as such, there is nothing. The steroids how we give after calculating this MDS. You can now understand in this question what they want you. They want you to calculate Madri's discriminant factor. So how to calculate Madri's discriminant factor? Anyone can tell me? Madri's discriminant factor we calculate by 4.6 into delta PT. Delta PT means change in PT. How much is the change in PT? Delta PT plus total bilirubin. Total bilirubin. So this is the formula to calculate Madri's discriminant factor. So let me say 4.6. Now what is the delta PT? PT was 20, corrected is 16. So 20 minus 16 plus total bilirubin is given in the MCQ, that is total bilirubin 7. It is given 7. So now you can see it is 4.6. 20 minus 16 will be 4 plus 7. So if you do the mathematics, 4.6, we are doctors, we are not that good in mathematics. In exam, you will not have pen and paper, or you will not get time. So remember, understand this 5. So if you multiply this by 5, even 5. So 5, 4, 20, 20 plus 7 is 27. So if you multiply this by, suppose if you understand this as 4, so 4 into 4, 16, 16 plus 7, 23. So value will come close to 25. Or if you want to be more precise, then we can do like this. So you can see it's 24, 18 plus 7. So it will be 19, 20, 21, 22, 23, 24, 25. So value will come close to 25. So 25 means it's still less than 32. Still less than 32. So there is, in this case, you will not give steroid. So let us see what they are asking, correct statement they are asking. Steroids are indicated in this case after ruling out variceal bleeding and sepsis along with alcohol suggestion. No. Steroids, we give steroids whenever MDF value is more than 32. So it is an incorrect statement. Clear? Then you can see pentoxifylline can be administered orally to improve survival benefit with alcohol abstinence. Now understand this, pentoxifylline we can give, but as per we have different trials. Like I told you, like pentoxifylline we use in practice, but there was a trial we call this STOPAHA trial. As per this trial, remember, pentoxifylline we can administer, but it will not have any survival benefit. This line is wrong. It will have some sort of antioxidant action, it will prevent further damage, but it will not have survival benefits. So even in many trials, they clearly said there is no impact on survival when we use pentoxifylline. So it's a wrong statement. And acetylcysteine along with steroid should be administered for survival benefit with alcohol cessation. Again, this N-acetylcysteine was compared with steroid. So it was again in many trials it was not superior to steroid alone. So steroids are better compared to N-acetylcysteine. So how you will manage this case? In this case, we will give only supportive therapy with alcohol abstinence. That's it. You give a good diet, good nutrition. When patient is admitted, you can give IV fluid. Simple. Multivitamin, we can give thiamine, because that is a good nutrition, good diet is recommended in this case. So correct answer for this question will be, I can say, option D. Yeah. Okay, moving to next one. Just try to understand this question. A 30-year-old female with a 2-year history of abdominal pain. So you can see first in the MCQ, young female. 2-year history of abdominal pain, bloating, alternating diarrhea and constipation, and urgency to defecate. She reports that her symptoms are worse after eating and during period of stress. She has no significant medical history. There is no, she is not taking any medication. There are no significant findings. Stool study, colonoscopy, CT scan are unremarkable. So you got like you can see young age. So any person who is less than 45 with abdominal pain at least once in a week, and pain is must. This abdominal pain is something that is must in the diagnosis. Then you can notice this patient, there should be normal investigations. All investigations are normal. So means we basically rule out every other disease. We do colonoscopy, endoscopy, biopsy, histology, everything should be normal. No anatomical defect. Then what we make a diagnosis of IBS. So in IBS, what patient will have? Patient will have abdominal pain. Abdominal pain is must. Plus any two of the following. Means this pain will be associated with change in consistency of stool, and there is change in frequency of stool. Means maybe there will be diarrhea, there will be constipation, or there will be alternate diarrhea and constipation. And remember, this pain is having association with defecation. So what I told in front of you, like pain in a young person with any of these two feature, we call this Rome 4 criteria. And Rome 4 criteria is used to diagnose IBS. Now what question they are asking? They are asking you like which are true statements. So like let us see this one by one. First is a peak amplitude of high amplitude propagative contraction in diarrhea prone IBS. Means they are basically asking about HAPS. Diarrhea prone IBS patient is seen to be increased compared to those in healthy subject. So just try to understand this. It is again a logical based thing when you study physiology, like high amplitude propagating contraction. These are more in diarrhea. So they are more when your gut is having more frequent stool. So this is a correct statement. They are more in diarrhea type compared to constipation type. In constipation type, what happens? Your food, your stomach or your intestine is loaded with food. So peak amplitude in diarrhea is always more. It's a correct statement. So I can say it is correct, true. T for true. Prolonged fasting aggravate IBS symptom. Now this is something I can say I'll be against of this statement because just try to understand this. Prolonged fasting, most of the IBS patient, what they prefer to be in faster state. Sometimes like they will tell you like, if I fast or if I defecate, then I will have some relief of symptom. So there is a fasting will generally provide relief in the symptom. This is a false statement. Non-smoker males of older age group are protected from post-infectious IBS. No. So understand this. This is I can say non-smoker males. If you ask me like non-smoker males of older are protected from post-infective IBS. So just try to understand this. When I talk about smokers, so just smokers, remember, smokers, they will actually have increased the increased risk of IBS is seen in smokers. Even I can say like a metabolic diversity or I can say this diversity of gut microbe. This is generally decreased in a patient of IBS. It is generally decreased. Diversity of gut microbe abnormally increase in patient with IBS. Diversity of gut microbiome, this is actually reduced. So this is actually reduced. So I can say here, you can notice this is reduced. So it is also a false statement. There is selective enhancement of serotonergic pathway in gut. So IBS exact pathology is unknown. So you can notice like patient, those who are having IBS, so there are I can say some enhancement of serotonergic pathway. There's some visceral gut hypersensitivity. So this is probably a true statement. So I can say here statement 1 is correct. Statement 5 is correct. Now coming to prolonged fasting, this will relieve the symptom. There will be relief of symptom. So if you see non-smoker males of older age groups are protected, that is true. What I told you, smoking will have increased incidence. The non-smoker, they are actually protected. So what else are at risk? Smokers, old age group, those who are getting recurrent infection and they are taking antibiotic for a long duration. So they are at increased risk. Non-smokers are of course protected. So this will also be a true statement. So if you see true statement are 1, 3 and 5. So these will be true statement. So 1, 3, 5. So answer for this question will be B. So just I want to tell you something more. So what I told you, in IBS patient, antibiotic therapy, any infection, then I can say bacteria growth, bacterial growth, then I can say decrease diversity of microbe, decrease diversity of microbe. Then I can say the patient who is having chronic inflammation, smokers, and these are the risk factor in a person, even those because some relation to stress. So sometimes type A personality or those who take a lot of stress. These are the risk factors. This will increase risk of IBS. This will increase the risk. So in antibiotic therapy, infection, bacterial growth, less diversity of microbe means less physiological strain of microbe, chronic inflammation, smoker, stress. These are increased risk of IBS. Now coming to next question, 25-year-old female, young female, 1 week postpartum. So why this postpartum word is given? So understand this word is given to make you understand like pregnancy is a state of hypercoagulation. History of headache for 3 days. CT head image is done in an emergency. What is true regarding this condition? So what you can see in the CT image, so understand this, in the CT image you can see on the right side this I can say enhancement of hyperdense sign. This is what we call this as cerebral vein, or I can say sinus is present. So it is basically telling you, let me zoom this. cerebral sinus thrombosis. So it's the case of CVD, cerebral vein thrombosis, sinus thrombosis. So how you will manage this? For this, what we need to give anticoagulants. For this, what we are using anticoagulants. So let us see the option one by one. Patient can be discharged with anti-migraine prophylaxis. There is no migraine, so there is no point. Migraine, remember, in migraine CT will be normal. In migraine CT will be normal. You will not see like this hyperdense sign in CT, so this is normal. IV TPA can be given for opening venous sinus. TPA is not given. TPA we give in stroke patient, and stroke is for artery, means cerebral artery thrombus or embolus. That's a wrong statement. IV heparin. Heparin is an anticoagulant. Subcutaneous low molecular heparin followed by warfarin. So these are anticoagulants. So anticoagulants we recommend. Prophylactic antibiotic and anti-seizure prophylaxis are recommended for all patients. So antibiotic we can give to prevent nosocomial infection if we are admitting the patient. Anti-seizure prophylaxis also not recommended for all patients. This is given for selective patient who will have increased chances of seizure. So it is not given to all patients. For example, a patient who is having cerebral edema, there's more chance of seizure. In that case, we can give. Moving to next question, is the following image signs of Parkinson disease, atypical Parkinson, is not wrongly matched. So basically they are asking what is the correct statement. So let's see first, hot cross bun sign. So we have, let me say we have Parkinson disease and we have atypical Parkinson. Atypical Parkinson, we sometimes also called as Parkinson plus syndrome. So what we have in Parkinson plus syndrome? क्या क्या होता है इसके अंदर? We have MSA. MSA के टाइप होते हैं, MSA P type, MSA C type, and MSA A type. P is Parkinson, C is cerebellum, and A is autonomic. Then we have PSP, progressive supranuclear palsy. MSA is multisystem atrophy. Third what we have? We have CBD, corticobasal degeneration. And fourth, it is again a sort of controversy, not given in many books. We call this DLB, but in some books it is given because in some books it is given as a type of Alzheimer disease, means it's a type of dementia. So in some books it is given with Alzheimer disease, dementia with Lewy body. Because here you will see feature of both Parkinson as well as Alzheimer. So if you see like patient is having MSAP, MSAC, PSP will have hummingbird sign. PSP will have hummingbird sign. A cortical basal degeneration will not have any specific sign on MRI. Then dementia with Lewy bodies also, but there will be no specific signs. Then MSA, if I talk about MSA, in MSA C type, in MSA C type, what we see? We see hot cross bun sign. And MSA P type, we see putaminal rim enhancement sign. And MSA again will not have any specific sign. So swallowtail, in Parkinson you can see a swallowtail, that's a loss of swallowtail. The swallowtail sign is seen where? It is seen in a case of typical Parkinson disease, but again it is not seen in every patient. Then we have two more variant of this disease, which are not called atypical, which we call them secondary Parkinson. Like one of them is Wilson disease. So Wilson disease can also cause Parkinson, and here you will find panda sign. In MRI you will find panda sign. There is one more called Haloverden-Spart syndrome. Haloverden-Spart syndrome, and in this Haloverden-Spart syndrome you will find eye of tiger appearance. Eye of tiger. So these are basically secondary Parkinson. So let's see first option. Swallowtail sign is seen in, they are asking you which is not wrongly matched. So swallowtail sign, where we see swallowtail sign we see in Parkinson disease. So this is a wrong statement. Hummingbird sign is seen in PSP. It is correct statement. Putaminal ring sign is seen in MSAP. And hot cross bun sign we see in MSAC. So these two are These two are wrong statement. Only one is correct, that is hummingbird sign. So let us revise all the sign in Parkinson. So just let me label this. This is number 1. Swallowtail sign, Parkinson. Number 2, putaminal, P for putaminal, P for MSAP. Right? P means Parkinson type of MSA. Hot cross bun, C for cross, C for cerebellum. This is 3rd. 4th is hummingbird sign in PSP. And 5th, you have to remember Wilson disease. Panda sign we also call as face of giant panda. And 6th will be eye of tiger appearance. So these are the signs which you have to remember. So let us see these signs. So what you can see in this first image, what you can see. If you see, this is what we call this hot cross bun sign. So hot cross bun sign where we see hot cross bun sign where C for cross, C for MSAC. If you see putaminal rim sign, this is seen where in a patient of MSAP, means Parkinson type. This is hot cross bun. Let me write cross bun. Here I am writing putaminal rim. Then you can notice here, this is hummingbird sign. Hummingbird sign we see in a patient with PSP. And this is something, if you see here, we call this loss of swallowtail sign or swallowtail sign. You can see this tail. This is lost in a patient with Parkinson disease. So we call this, we see in Parkinson disease. Actually, it is not called swallowtail. That the actual full name is loss of swallowtail sign. We call this loss of swallowtail sign. Normally it is present. So you can see this is present normally, but here this will be disappeared. So loss of swallowtail sign. So these are the signs. Moving to next one, a 50-year-old male with no known comorbidities. Present to emergency room with complaint of loose stool and vomiting. Loose stool and vomiting. So there is a chance of hypovolemia. On examination, he was noted to have sunken eyeball. There's dehydration, decreased skin turgor, means again signs of dehydration. So dehydration is present. Dehydration is present. Decreased urine output. Serum sodium is 120. Serum sodium value less than 120 means there is 120 means there is more chance of seizures. So there can be some neurological impairment. Seizures can occur. Osmolality is 256. Normal urine spot sodium. So urine spot sodium is normal, and urine osmolality is normal. What is the likely cause of hyponatremia? So let's see this question. If you see like beer potomania is due to beer. So this is like a very rare cause. Again, not seen in every patient. Here it is mainly attributed due to low solute intake. It is due to low solute intake, right? And whenever you will consume, again you will take a good diet, you will take a lot of fluid, this will be normal. Means you will take a good diet, good nutrition, you'll stop beer, this will be corrected. Pseudo hyponatremia is something which we can see in a patient with hyperlipidemia. And you can see this in a patient with hyperglycemia. So it is said like whenever you will notice like every 100 milligram per deciliter increase in glucose, every 100 milligram increase in glucose, you have to remember sodium will decrease by 1.4. So 1.4 sodium will decrease. So that is why you can see a pseudo hyponatremia is commonly seen in diabetic patient and a patient with metabolic syndrome who have dyslipidemia. SIADH, if you see, SIADH is a case of euvolemic hyponatremia. Euvolemic hyponatremia is what you will notice in this condition. In SIADH, you will notice like a urine sodium value is more. Urine sodium is more. So when you try to see this type of question, you will get an idea. So just let me make a flow chart to make you understand. I can divide hyponatremia into three categories. So hyponatremia I can divide into three categories: hypovolemic, hypovolemic, euvolemic, and hypervolemic. Hypervolemic. And if you notice, like hypervolemic, this is something which we can see in AKI or CKD patient. We can see this sometime in heart failure also. And if you see like euvolemic type, this is seen in many condition. This euvolemic type is seen in SIADH. So SIADH you will see euvolemic type. Then hypovolemic type. Here like there is importance of checking urinary sodium. So this you can see in a patient who is having diarrhea or vomiting, or I can say any person who is having like any sort of extra renal losses like third spacing. Then you can see there is one more type of this. Sometime we can have renal losses. So answer for this question is simple. It's hypovolemic type. So you can notice hypovolemic type. So diarrhea, vomiting, and third spacing. Here you will notice like urine sodium value will be less than 20, and in case of renal, urine sodium value will be more than 20. It will be more than 20. Now coming to SIADH will also have urine sodium value more than 20. And AKI-CKD, again due to AKI-CKD, you can notice here value will be more than 20. Heart failure, it can be normal. It can be normal or less. So when caution is clear cut, it's a case of like beer bottomania, there is no as such history of beer. So it's diarrhea, vomiting. So that's the case of hypovolemic hyponatremia. Simple. Okay, now they ask you question on ECG. So what you can notice in this ECG. So let us see in this ECG what we can see. If you notice here carefully, there is this is R. So you can notice there is a constant RR. Constant RR. Then R, this is T, this will be P. So you can notice there is constant PP and constant RR. So this type of ECG, what we call as AV dissociation. Means atria and ventricles both are moving at their own separate rate. We call this AV dissociation. And AV dissociation is something that is seen in third degree AV block or complete third block. Third degree AV block or complete third block. That's very, very important. One more thing they can ask you, like in third degree AV block, what we see constant PP. Constant PP and constant RR. Means both atria and ventricles, they are moving at their own speed. Okay, now understand this and try to answer and understand what you can see in this. What you can see in this. If you see here, what you can notice this is P, starting of P to starting of R. This interval is called PR interval. Right? So what I am showing you here, just try to understand. PR interval. PR interval. PR interval. This is I think longest of all. Almost 2 box. In other cases, you can see like it is like a 1.5 box or something. So you can see PR interval is prolonged. Then here, if you want to see, this is QRS. So let me again label this. This is QRS. This is T. This is P. So after P, what you can notice? You can notice there is a drop beat. This is called, there is no QRS. So this is what we call, you can notice like there is a prolonged PR interval with a drop beat. Prolonged PR with a drop beat, what we call this Mobitz 1. Mobitz 1, also called as Wenck-Bach phenomena. Wenck-Bach phenomena. Now what you can see here, already hint is given, just I try to answer this. Here what you can notice in this ECG. You can notice this is P. This is P. Then if you see what we have, after P what we have P, then here also again P, P, Q, R, S, T. So if you see PR interval, let me make this PR interval, PR interval, PR interval, then P, then what we have a dropped QRS, dropped QRS. So in this case, what you can notice like PR interval is prolonged, again a drop QRS. So what you can notice there is like intermittently these P waves are not conducted, means there is a drop QRS. So this is what we call this Mobius 2. We call this Mobius 2. And what we call Mobius 2? Mobius 2 we call Hayes block. Mobius 2 or Hayes block. Again, Mobius 1 and 2, these are types of I can say second degree AV block. So here you can notice like PR is almost constant. What you can notice here? Try to answer this. You can notice PR interval. So let me start with this. PR, 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 PR. So PR is prolonged. PR is prolonged, but I can say it is more than 200 or more than 5 small blocks. There is no drop beat. This is first degree AV block. It is first degree AV block. So all other examples we have discussed. Okay, coming to next question. A 62-year-old gentleman, 62 is the age, attended an outpatient clinic with complaint of generalized weakness and low backache for 1 month duration. CBC hemoglobin is 8.2, TLC is 5.6. So hemoglobin is low, TLC is okay, platelet count is 179, again low. MCV is 92, reticulocyte count 1.4, ESR 110, very important. High ESR, low backache. So my brain is going towards multiple myeloma. Total protein 8.9, albumin 2.9, creatinine is 2.2, slightly increased. Calcium is normal. MRI spine reveals fracture of L1 vertebra. So again, you can see like patient is having all the crab features which I have discussed in multiple myeloma. There is, you can notice like calcium. Let me say calcium is normal in this case. MRI reveals compression of fracture with paraspinal soft tissue mass. Light thick lesions are seen in dorsal and lumbar vertebra. SPEP showing M band, means M spike is there. IgG kappa on immunofixation. Bone marrow examination showing 22% plasma cells. So diagnosis is simple. Diagnosis is multiple myeloma. So I hope most of you have made the diagnosis. Now what they're asking you, like which investigation is going to be least useful in this patient? So multiple myeloma, we do a series of investigations. So we can do like Benz-Jones proteins in urine. Then we can go for like SPEP. So what investigation we do? So we can go for a CBC, what is done here. Then ESR, again ESR is ready here. CBC, ESR, what else we do? We do a KFT, we do skull X-ray. Sometimes we do MRI spine. That's also done. Then we can go for like Benz-Jones protein in urine. Confirmation we assume by I can say bone marrow examination. Then we can also check for in SPEP, you can see M spike. So these are the tests we do to make a diagnosis. Electrolyte also we do, like serum calcium. So understand, once you make a diagnosis, we make a diagnosis, then what we check? We check for some other things. So understand this. We have something called ISS. ISS means International Staging System. As per ISS, what we have? We have beta 2 microglobulin. Beta 2 microglobulin. And one more thing, albumin. Right? So these are two things. And out of this, beta 2 microglobulin is very important. This is more important. So this is these two tests. Generally what we don't check albumin, because albumin can be low in many other things. So beta 2 microglobulin and albumin, these are two values and out of this, a single most effective is beta 2 microglobulin. These are the tests which can predict the future of the patient. So these two are tests that we do for prognosis. Now coming to what is given, something called serum light chain. So serum light chain. So serum light chain value, understand. So light chain value, if it is more than 100, more than 100 means this is considered a myeloma defining illness. Myeloma defining illness. So that also we can check. And lastly, I can say, like in this ISS was revised, that is called a RIS. RIS means Revised International Staging System. In this, we have one more component that is added as LDH. So LDH is added. So again, this LDH is added. Again, this is for risk stratification and to decide the prognosis of disease. So serum free light chain, I told you values are more than 100. That is called myeloma defining illness. So this we do. ये हम करते हैं. क्वेश्चन पूछ रहा है क्या लीस्ट यूजफुल है. बीटा 2 माइक्रोग्लोबिन इज द सिंगल मोस्ट इफेक्टिव टेस्ट फॉर प्रोग्नोसिस. सबसे अच्छा टेस्ट ये होता है. ये क्वेश्चन लास्ट ईयर भी आया होगा एग्जाम में. इफेक्टिव टेस्ट. रेडियो आइसोटोप स्कैन नहीं करेंगे, करने का कोई फायदा नहीं, बिकॉज आपने MRI करा लिया है. LDH is recently added in ISS course. So these three things are done. Radio scan is not routinely needed. Okay, 51-year-old male presenting with a complaint of shortness of breath. सांस फूल रही है. X-ray and HRCT images are shown below. What is the most likely diagnosis? So in X-ray, what you can notice, again, age 51 है. So based on this, you need to make a diagnosis. Now I can say some hilar lymphadenopathy here, and here I can see some GGO. GGO means ground glass opacity. So what else I can notice? I can notice some small thin walled cyst. Now let us see this. If it is a pulmonary edema, if it's a pulmonary edema, you can notice some sort of cardiomegaly. In pulmonary edema, what we can see? We can see cardiomegaly. You can see whitishness. You can see bilateral whiteout. If you see bilateral whiteout without cardiomegaly, that is what we call as the ARDS. Right. So what else you can notice? Sometime you can notice like curly B lines. So again, those things are not evident. Curly B lines. Pulmonary alveolar proteinosis. Understand this condition. If you see, it is a rare condition. So generally, it is seen in a pediatric population. Here you can notice, you can see some GGO, right? But the cysts are absent. Cyst will be absent. Idiopathic pulmonary fibrosis. Right. Here you will notice like more reticular opacity will be on the basal side. You can notice on the basal aspect, means on the base of lung. Pneumocystis carini is the last option left out by ruling out others. So that is the diagnosis. So basically in pneumocystis carini pneumonia, what we see? In this pneumonia, we see like patient will have a bilateral infiltrate. So you can notice bilateral hilar lymphadenopathy. Plus you can notice cyst, and later on these cysts can have ground glass appearance. So answer will be pneumocystis carini pneumonia. Moving to next one, again ये तो थोड़ा easy question है, try to answer. A 31-year-old male patient, known case of bronchial asthma का case है. For the past 5 years present with history of multiple exacerbation. बार बार अस्थमा के exacerbation हो रहे हैं despite regular medication and required hospitalization. HRCT is then suggestive of bilateral bronchiectasis and mucus impaction. Following is not correct for this clinical condition. So understand this. This patient is having, I can say, a recurrent exacerbation of asthma. So if you see like there is mucus impaction, so these are the hint in the MCQ. तो पहले hint क्या मिल रही है क्वेश्चन के अंदर? Multiple exacerbation episode हो रहे हैं, known case of asthma, then bilateral bronchiectasis and mucus impaction. So these all hint are suggestive of ABPA. अब इसको समझो. ABPA means allergic bronchopulmonary aspergillosis. ये ज़्यादातर asthmatics को ही होता है. और अगर बच्चों में होगा तो सिस्टिक फाइब्रोसिस के पेशेंट को होता है. So mostly it will affect asthmatic cases. So how you will approach this patient to make a diagnosis of this? What we check? We check IgE, right? IgE against Aspergillus fumigatus. Then we can also check the level of total IgE, serum IgE. और सीरम आईजी को हम डायग्नोस हम बनाने के लिए क्या करना, आईजी अगेंस्ट एस्पर्जिलस फ्यूमिगेटस. बट अब बार बार उसको तो नहीं करोगे, तो प्रोग्नोसिस देखने के लिए फॉर प्रोग्नोसिस व्हाट वी चेक, सीरम आईजी, कि पेशेंट आपका ठीक हुआ है या नहीं हुआ है, राइट. एंड वन मोर थिंग व्हाट वी सी हियर इज स्ट्राइकिंग eosinophilia. Striking eosinophilia. So serum Ig levels are used to monitor its treatment. Yes, it's the correct statement. Not correct पूछा, this we use. Specific Ig Aspergillus fumigatus is helpful in diagnosis. Yes, it's also correct. ये भी सही है. तो not correct पूछा, this is the correct statement. It's the correct statement. Predominant peripheral, no. यहाँ पर generally क्या मिलता है, you will notice like patient will have more of a central bronchiectasis. So this is something that is a wrong statement, and that is the answer. This says patient will have central bronchiectasis, and poor control asthma is incorrect. So it is seen mostly in asthmatics. So predominant peripheral bronchiectasis is not seen. Instead, what we see? We see central bronchiectasis. Central bronchiectasis. Clear? Okay guys, coming to next question. Interpreted the image B with respect to thromboelastographic and hemostasis. Given image A as normal thromboelastogram. So just try to understand this. This is a normal thromboelastogram, and we have to interpret this image. So basically, like it is one of the trending topic which is frequently tested in INI-CET exam. So starting with some basic information of this topic. So let me show you the normal elastogram first. So you can look at this. In this first, what we see like this first time is called reaction time. Now understand what I mean by reaction time. Reaction time we represent as R. This reaction time is nothing. It is a time till initial clot formation. Means there is initial fibrin clot formation. That time is called reaction time. So this part, so if I shade this with blue, this part is called, this part which I am drawing now, this is called reaction time. So basically this is telling you like how your fibrin clot is formed. Initial time that is spent. Then what we have, understand this, time duration or time elapsed this clot to reach a fixed strength. That time is what we call. So let me shade this with another pen. So you can see this time means time elapsed, I can say, to attain a certain level of firmness in the clot. This is called K time. So this is what we call this K time. So from here to here, this time is called K time. So if I shaded with the blue, that is your reaction time. Then next is what your kinetic time or K time. Then this angle we can see, which is normally 47 to 74 degrees. So simple, it's 47, ulta kar do 74. So this angle is called alpha angle. We call this alpha angle. This angle is called alpha angle. And ultimately what you can notice, any clot will achieve like its vertical amplitude strength. Means you can see overall stability of clot we can judge by this MA. MA is maximal amplitude. So this will be maximal amplitude. Clear? Then what is seen, you can notice like ultimately it start lysis. So that is called LY30. LY30 means this is the period. Means you can notice now this clot is having lysis. So this is telling you about lysis of clot, right? So this is generally seen 30 minutes after your maximal amplitude. So if I want to draw this again in your normal thromboelastogram, just try to understand this with me once again. So let me take a different color pen to make the annotation clear. Suppose this is, I can say this will be the first, that is R means reaction time. Then you can notice in any clot, what you can notice this is what we call a kinesis, that is called your K time. So in both sides, here as well as here, we call as K time, or I can say kinetics or clot formation time. Then what we have an angle. So this angle is called alpha angle. Then this clot is reaching MA. MA means maximum amplitude. And ultimately here you can see that the start lysis, that's called fibrinolysis. But again, it is here you are just seeing the step, so there is no lysis. So this will be, if there is lysis, what will happen? This will be moving in this direction like this. So this is what we call this lysis. Lysis, or we call this LY30. Now based on this, you will get an idea, like each of these components have a significant role. So what are these different components and how we should interpret such question? So starting with the first component, what we have R time. So let me say first component is R time. R time means reaction time. Then I can say second important component will be K time. K time. Third, I told you alpha angle. Alpha angle. Fourth, we have discussed a maximal amplitude. Maximal amplitude. And fifth is your LY30, that is clot lysis. Now just try to understand this, the significance of each of these terms. Significance of each of these terms, and sometimes they ask you question related to like when these will be defective. So they can ask you question related to the treatment of this. So here I'll discuss a definition. Then we can have a defect and how you will manage. Then sometimes they ask you like image based question. So I'll show you like same thing in thromboelastogram form. So first, the sequence is very very important. So first thing is you have to remember the sequence. So आपको ये sequence कैसे याद रखना है? So sequence याद करने का तरीका मैं आपको दे रहा हूँ, that is रजनीकांत. रजनीकांत is alpha male. तो रजनीकांत is alpha male. अब इसको समझो एक बार. What is a definition of this reaction time? So understand this. It is a time till initial clot formation. This is nothing. It is time till initial clot formation, right? So means when fibrin clot is formed, and that how it is formed, it is due to clotting factors. So when this time will be defective, so understand this time will be defective whenever there is a clotting factor deficiency. मैंने short में लिख दिया, like for example I can say hemophilia A, B, C, then or it could be due to use of anticoagulant toxicity. For example heparin, warfarin किसी को ज़्यादा चल रहा है. In दोनों ही केस में like you are having clot, means anticoagulants, how they act, they will act on clotting factor. How you will manage this? You will manage this by giving FFP, fresh frozen plasma. If it is individual clotting factor deficiency, then we can also use like individual clotting factor. Like for example hemophilia A में आप क्या ले सकते हो? Recombinant factor 8. Coming to K time, understand this. It is nothing. It is time elapsed till a clot will reach to a particular strength. Till clot reaches a fixed strength. And that how much is that strength? That strength is 20 mm. That strength is 20 mm. So basically ये आपको क्या बता रहा है? Time elapsed till clot reach a particular fixed strength. सो मेनली ये स्ट्रेंथ कब आती है, जब फाइब्रिन जाके जमा होगा, और आई कैन से फाइब्रिनोजन जाके जमा होगा. सो बेसिकली हियर व्हेनेवर देयर इज अ डिफेक्ट इन फाइब्रिनोजन, देन दिस के टाइम विल बी अफेक्टेड. सो फाइब्रिन के डिफेक्ट में क्या करोगे, कौन सा होता है फाइब्रिन का डिफेक्ट, क्या बोलते हैं, ए फाइब्रिनोजेनीमिया. ए फाइब्रिनोजेनीमिया. फाइब्रिनोजन एफएफपी के अंदर बहुत सारे क्लॉटिंग फैक्टर होते हैं, बट वी हैव क्रायोप्रेसिपिटेट दैट इज हैविंग मोर कंसंट्रेशन ऑफ फाइब्रिनोजन. तो इसके ट्रीटमेंट में आपको क्या देना है, क्रायोप्रेसिपिटेट. एफएफपी भी दे सकते हो, but mainly we will prefer cryoprecipitate. Coming to alpha angle, this is basically telling you like how quickly your fibrin is accumulating. So that is basically telling you information on speed of fibrin accumulation. Speed of fibrin accumulation. So understand, speed of fibrin accumulation. So basically angle hota hai. So if you see normal values, this angle is 44 to 74 degree. So this is also telling you like how strongly fibrinogen is linking with fibrin. So that is again a defect of fibrinogen. तो इसमें भी आपको क्या देना है, क्रायोप्रेसिपिटेट देना है. We can also use FFP in both the scenario, but cryoprecipitate is more effective. Coming to maximal amplitude, understand, max amplitude means it is nothing, it is highest vertical amplitude. So basically it is telling you like maximal strength of the clot which is forming. So it is telling you maximal strength, right? And this is basically depending on the availability of platelets as well as clotting factor. So basically this is a platelet dependent. It will depend on platelet, right? So both I can say qualitative and quantitative platelet defect. In platelet defect, you can see this maximum amplitude will be defective. This will be changed. So for treatment, what we can use a recombinant platelet. We can use platelet. So platelet in which form? We can use SDP, single donor, or we can use RDP. Then here also we can use desmopressin. And coming to last thing, that is LY30. It is telling you like what is the extent of fibrinolysis. Means basically ये आपको क्या बता रहा है, extent. I can say extent of fibrinolysis. Extent of fibrinolysis. So means यहाँ पर क्या होगा, ये बताएगा आपको कि कैसे आपका clot lysis हो रहा है. So this LY30, you can notice, this is something, this parameter will be effective whenever there is like overuse of thrombolytics. So thrombolytic का over होता है. Overuse means I can say suppose STK, urokinase, streptokinase. Thrombolytics, right? Now just try to understand this. Suppose there is a thrombolytic toxicity, so how you will manage? In this case, how we manage? We give aminocaproic acid. And we can use epsilon aminocaproic acid, or we can use tranexamic acid. So एक एक करके आपको ये सारे डिफेक्ट पढ़ने हैं. Now they can ask you this type of image. So just look at this image with me and you will get an idea what I want to explain here. So पहले तो आपको याद रखना है रजनीकांत अल्फा मेल. So in normal I can say this is your R, this will be K, और यहाँ से जो एंगल बनेगा, तो here the angle they make, this angle will be alpha angle. Then this will be your maximal amplitude. So in this image what you can see, you can notice R, K, maximal amplitude, alpha angle, right? सब कुछ normal है, everything is normal. So this is a normal image. Now compare to this one, इसको पहले आप समझो. Just try to understand this. Here in this image what you can notice, you can see, अगर मैं बात करूँ R की बात करूँ तो R is prolonged. R is prolonged. So K is also prolonged. R is prolonged. K is prolonged. Right. एंड इफ यू नोटिस लाइक जब आर प्रोलॉन्ग हो गया तो एंगल कैसा हो गया, एंगल इज रिड्यूस्ड, एंड इफ यू सी मीन एम्पलीट्यूड कैसा हो गया, दैट्स ऑल्सो रिड्यूस्ड, सो मीन एम्पलीट्यूड reduced. Now see, R is prolonged, K is prolonged. It means there is a more time. There is, I can say, there is more clotting factors. Clotting factors are consumed. Somewhere it is consumed. So it could be like a defect of clotting factors. So ऐसा कब हो सकता है? जब reaction time, I can say, बढ़ जाएगा, kinetic बढ़ जाएगा. Whenever a person is having either clotting factor deficiency or a person who's having, I can say, anticoagulants overuse. So I can say it is due to anticoagulants, means heparin, warfarin, or hemophilia, means clotting factor deficiency, like hemophilia A, hemophilia B, hemophilia C. अब इसको देखो, just try to understand this. Suppose मैंने बताया था, this is what we say, we call this R. So R is normal, right? If you see K is little bit prolonged. So R is normal, K is prolonged, right? And what about angle here? Angle, you can notice angle is almost, I can say, little decrease, or but MA, if you see, आपको मेन इंपॉर्टेंट चीज़ फोकस करनी है, MA, मैक्सिमल एम्पलीट्यूड, इज समथिंग दैट इज रिड्यूस्ड. अब इसको समझो एक बार. मैक्सिमल एम्पलीट्यूड इज टेलिंग यू अबाउट प्लेटलेट. अगर मैक्सिमल एम्पलीट्यूड छोटा होगा, इसका मतलब प्लेटलेट का डिफेक्ट. सो इट इज टेलिंग यू लाइक आइदर इट कुड बी अ प्लेटलेट डिफेक्ट, or I can say due to or some drugs which are acting on platelet. So ऐसा कहाँ पर होगा, platelet blockers, or it could be platelet defect. So you can see this in dengue patient, you can see this in patient of ITP, TTP. Now moving to next one, if you see here, you can notice R is normal. तो R कैसा यहाँ पे normal, right? And if you see, forget बाकी सब कुछ, अगर आप देखोगे this K is bit prolonged, but if you see this is called, ये MA आ गया, and ultimately here you can see this is what LY30. So this is, you can see straight away सीधे क्या आ गया, यहाँ से downfall होना start हो गया. This is what we can see, like MA कम होता चला जा रहा है, this MA is continuously decreasing, and you can notice LY30 means ये जो tail बन रही है, this tail is prolonged. So MA is decreasing, and LY30, this is prolonged. तो ऐसा कब होगा, जब lysis होगा, when there is more lysis means fibrinolysis. Whenever there is fibrinolysis, तो fibrinolysis किससे करते, thrombolysis. Fibrinolysis means you can use urokinase, you can use STK, streptokinase, you can use alteplase or TPA. Now understand, in this question you can notice like R कम हो गया. अब इसको समझो एक बार, R क्या बता रहा है, R is telling you about time till initial clot formation. इसका मतलब क्लॉट जल्दी बन गया. If you see K, so I can write here R and K, they both are decreased. And if you notice MA means maximal amplitude कैसा हो गया, ये बढ़ गया, and angle is also bit increased. This is means सब कुछ जल्दी हो रहा है, एम्पलीट्यूड बड़ा हुआ आ रहा है एकदम से, एंड मोर और लेस यू विल गेट एन इमेज विच इज स्लाइटली बिगर एंड ब्रॉडर दैन नॉर्मल. अगर आप इसको कंपेयर करोगे, देन कंपेयर दिस विद द नॉर्मल इमेज. इससे भी ज़्यादा बड़ा आ रहा है, एम्पलीट्यूड बड़ा आ रहा है, इसका मतलब कोगुलेशन ज़्यादा हो रहा है. इट्स टेलिंग यू हाइपर कोगुलेशन. एंड कमिंग टू लास्ट वन, यू कैन सी लास्ट वन मीन्स वी हैव DIC. तो देखो DIC की दो स्टेज होती हैं. सो इनिशियल स्टेज में इट विल हैव हाइपर कोगुलेबल स्टेट. तो शुरू में तो बिल्कुल हाइपर कोगुलेबल जैसा दिखेगा, सारा कुछ सेम. सो ऑल जो मैंने यहाँ पर लिखा है, दैट सेम थिंग विल बी हियर, सेम डिक्टो सेम होगा. उसके बाद नेक्स्ट व्हाट यू सी, यू विल नोटिस देयर विल बी हाइपोकोगुलेबल स्टेज. सो नेक्स्ट स्टेज विल बी हाइपोकोगुलेबल. और हाइपोकोगुलेबल में क्या होगा, डिसेमिनेटेड इंट्रावास्कुलर कोगुलेशन. सो हियर यू कैन सी, पहले तो कोगुलेशन ज़्यादा होगा, फिर देयर इज क्लॉट लाइसिस, सो यू कैन नोटिस देयर इज आई कैन से हाइपोकोगुलेशन, क्लॉट कम होगा, क्लॉट कम कैसे होगा, ऊपर देखो अब, नाउ आर विल बी प्रोलॉन्ग, so that is hypocoagulable. So this is something what we see in DIC. So basically आपको ये ग्राफ याद रखने हैं, और समटाइम दे कैन आस्क यू लाइक हाउ यू विल मैनेज ईच ऑफ दिस डिफेक्ट्स. तो अब मैं आपके सामने क्वेश्चन को दिखाता हूँ, तो आपको थोड़ा आसानी होगी. नाउ लुक एट दिस क्वेश्चन केयरफुली. तो लेट मी फर्स्ट कंपेयर दिस नॉर्मल. सो नॉर्मल में आपको क्या बता रहा हूँ, फर्स्ट व्हाट यू कैन नोटिस, पहले आप देखो ध्यान से क्या दिख रहा है आपको. दिस इज योर आर. R means, R का मतलब बताओ मुझे. It is a time till initial fibrin clot formation. Then you can notice this is what? K. What is K? It is time elapsed till clot formation. एक fixed strength आ जाती है 20 mm की. Then what we have? We have alpha angle, means alpha angle कैसे क्या बताएगा आपको? How fast your fibrin is accumulating. This is your MA. MA means maximal amplitude. और यहाँ पे LY30 नहीं दिखाया बिकॉज लाइसिस नहीं हो रहा है. अब इसमें आप देखो क्या दिख रहा है आपको. जस्ट ट्राई टू अंडरस्टैंड दिस. व्हाट यू कैन नोटिस इन दिस स्लाइड, क्या आपको दिख रहा है, पहले इसको फोकस करो. व्हाट यू कैन सी हियर, यू कैन नोटिस दिस इज आर, राइट. सो इसमें आपको बेसिकली दिख क्या रहा है, यू कैन नोटिस आर. तो आर इज इंक्रीज्ड. अगर मैं आपको कंपेयर करूं, ऐसा हमने कहाँ देखा था, you can notice this type where we have seen here. So R is increased. So R बढ़ गया है. Then if you see this is K. K is also increased, right? So you can notice R is increased, K is increased. तो R क्या बता रहा था? What was R telling you? R was telling you about, see this is reaction time, clot formation. तो R is prolonged. And K is also prolonged. So R and K both are prolonged. If you see mean amplitude कैसा आ रहा है, mean amplitude is decreased. So if I want to write this in form of theory, I can say R is increased, K is increased, mean amplitude is decreased. And if you notice here, अगर आप यहाँ notice कर रहे हो, angle will also reduce because angle छोटा हो गया. You will notice here angle will reduce. Now let us see options one by one where we can see this. तो देखो hypercoagulable state में क्या होगा, hypercoagulable state में ऐसा आएगा नहीं आएगा. तो अब आप मुझे बताओ सीधे ये कहाँ का डिफेक्ट होगा. What will be the defect here? If you see this type of image, what will be the defect? You will see, you will notice R बढ़ रहा है, K बढ़ रहा है. इसका मतलब clotting factor में प्रॉब्लम है. Clotting factor problem, so answer will be A. If you see platelet dysfunction or thrombocytopenia, तो platelet dysfunction में you will get this type of graph. तो platelet dysfunction you will get this type of graph. This type of graph you will get. And अगर मैं आपको बात करूँ पेशेंट को फाइब्रिनोलाइसिस हो रहा है, TPA का यूज हो रहा है, तो उसकी टेल लंबी आएगी. That this will be the graph. Thromboelastogram will show like this. So it is due to TPA. And lastly is what you can notice if they ask you question on hypercoagulable state, so वो इससे भी बड़ा आएगा. It will be bigger than this. Am I clear? So this is about thromboelastographic study. बस आपको जो याद रखना है, like Rajnikant alpha male, very very important. Okay, moving to our next question. 45-year-old female present to OPD with complaint of exertional dyspnea. तो 45 एज है, सांस फूल रही है, hoarseness है, fatigue है. She mentioned occasional hepatitis, difficulty swallowing, history of recurrent stroke, bilateral pitting edema, heart failure में जा रहा है patient, bibasilar rails, diastolic murmur, mid clavicular line, loudest one, opening synapse noted. So I can say based on the history it is an MS converting into CHF. So patient को mitral stenosis है, and they are asking you all of the following are X-ray changes except. तो अब इसको पहले समझो, लाइक MS के पेशेंट के अंदर व्हाट आर द एक्सरे चेंजेस. सो व्हाट आर द एक्सरे चेंजेस, देखो कई बार ऐसा होता है एक एक्सरे के बिहाफ पे रेडियोलॉजिस्ट कैन डायग्नोस MS. तो समटाइम लाइक व्हेन यू आर कंफ्यूज बट जस्ट एक सिंपल एक्सरे के बिहाफ पे आप MS को डायग्नोस कर सकते हो. तो MS के अंदर ऐसे क्या फीचर आते हैं, दैट इज समटाइम दे आस्क यू इन एग्जाम. तो फर्स्ट चेंज आई कैन से First, you will notice like there will be a straightening of heart bottom. There will be straightening of left border of heart. Basically, what we call this? We call this cardiac silhouette. So that left heart border of cardiac silhouette, that is straight. Then you can notice like a pulmonary artery will be prominent pulmonary artery. और क्या दिखेगा? You can notice a posterior displacement of esophagus. Right? Why this occur? Because of enlarged left atrium. Left atrium enlarged हो जाएगा. What else? Sometimes you can notice curly bee lines. कभी कभी आपको क्या मिलते हैं? कर्ली बी लाइन्स. कर्ली बी लाइन्स याद रखना, हमेशा नहीं मिलती. राइट. सो दीज आर बेसिकली हॉरिजॉन्टल लाइन्स. राइट. और कहाँ मिलेंगे? दीज आर हॉरिजॉन्टल लाइन इन लोअर एंड मिडिल लंग फील्ड. So these are the four classical changes that you have to remember. So let us see the option. Left ventricular enlargement, पहले ऑप्शन गलत दे दिया. लेफ्ट एट्रियल का enlargement होता है, वेंट्रिकल का नहीं होता. कर्ली बी लाइन मिलती है, यस मिलती है. स्ट्रेटनिंग होता है, यस. परमानेंट होती है, यस. आंसर विल बी लेफ्ट वेंट्रिकल. सो याद रखना, इसमें लेफ्ट एट्रिया का enlargement होता है, उसकी वजह से इसोफेगस पोस्टीरियर डिसलोकेट हो जाता है. ओके, अब ईसीजी तो सिंपल है. सो व्हेनेवर यू गेट एन ईसीजी क्वेश्चन, पहले आप हिस्ट्री देख लो, फिर इमेज को देख लो. So look at the history. 62-year-old male present with smoker, chronic case of hypertension, emergency room, complaint of severe chest pain, and was pressing his chest with a fist. So means आपको समझ में आ गया, it could be angina or MI. History समझ में आ गया. He described pain as crushing and squeezing in the central part of chest, radiating to left arm. BP, patient appears pale. BP is high. Heart rate is 110. SpO2 is 94. ECG is given below. सो इन दोनों में से एक आंसर है. अब इसको समझते हैं एक बार कि ऑप्शन, लेट्स सी द ऑप्शन. इंफीरियर वॉल, एंटीरियर वॉल. सो जस्ट रिमेंबर, फॉर एंटीरियर वॉल यू विल सी चेंजेस इन लीड V2, V3, V4. इंफीरियर वॉल में जो चेंजेस मिलेंगे आपको लीड 2, 3 और AVF में मिलेंगे. अब नॉन ST एलिवेशन MI में आपको ST एलिवेशन होगा ही नहीं, मार्कर्स पॉजिटिव होंगे. इट कुड बी इन डिफरेंट टाइप ऑफ लीड, किसी भी लीड में हो सकता है, डिपेंडिंग ऑन कहाँ का इन्वॉल्वमेंट है. देन इफ आई टॉक अबाउट लेटरल वॉल MI, यू विल नोटिस लेटरल वॉल में चेंजेस कहाँ मिलते हैं, यू कैन नोटिस. सो लेट अस फर्स्ट सी दिस ECG. आपको क्या दिख रहा है? यू कैन नोटिस ST एलिवेशन इन लीड 1. मैं थोड़ा सा इसको थिकनेस आई एम रिड्यूसिंग सो दैट यू कैन ईजिली सी. तो यू कैन सी लीड 1 में चेंज है, AVL में ST एलिवेशन आ रहा है. Then you can notice changes in V5 and V6. So if you see changes in lead 1, AVL, V5, V6, it is telling you information of lateral wall MI. Simple question है. देखो anterior wall में कहाँ बताया था? V2 से V4 में, inferior wall में 2, 3 AVF में. तो again an easy question. A 32-year-old female present with medicine OPD with a complaint of frequent heartburn, which is refractory to standard therapy. Heartburn हो रहा है और standard therapy means PPS improvement नहीं आ रहा है. तो young age है. She was diagnosed with systemic sclerosis. So systemic sclerosis में dysphagia is very common. क्यों? Because देखो fibrosis हो जाती है. On a manometric evaluation, LES was found to be hypotensive. LES is hypotensive with absent esophageal motility. Following is true regarding this condition. Scleroderma esophagus with hypotensive LES with absent esophageal motility. इसको समझो पहले एक बार. This term was coined like scleroderma. इसको बोलते थे scleroderma esophagus with a hypotensive LES tone. So initially it was reported in systemic sclerosis. एंड आई कैन से इन रोमेटोलॉजिकल कंडीशन. उसके बाद ऐसा देखा गया कि देर आर मेनी पेशेंट, मोर देन 50% पेशेंट हु डोंट हैव एनी रोमेटोलॉजिकल कंडीशन एंड दे कैन ऑल्सो हैव दिस. इसलिए इस टर्म को हटा दिया. दिस टर्म वाज रिमूव्ड, स्क्लेरोडर्मा एसोफेगस. सो हियर इट इज एक्सक्लूसिवली सीन इन पेशेंट विद सिस्टमिक स्क्लेरोसिस एंड अदर कोलैजन वास्कुलर डिसीज. नो, रिमेंबर इट कैन बी सीन in many non-rheumatic condition. There are many non-rheumatic condition, वहाँ पर भी ये हो सकता है. So it is a wrong statement. They are asking you correct statement. This destruction of the muscularis propria, सही बात है, muscularis propria का destruction होगा, वहाँ पर TGF बीटा की वजह से फाइब्रोसिस होगी एंड इंक्रीज नो. जब फाइब्रोसिस होगी तो इंटरस्टिशियल सेल्स ऑफ कहाल का नंबर कम होगा. तो देखो ऊपर आधा स्टेटमेंट तो सही है, बट दिस स्टेटमेंट इज रॉन्ग. देयर इज डिक्रीज इन नंबर नॉट इंक्रीज. सो अगेन पूरा स्टेटमेंट को गलत हो गया. लॉन्ग स्टैंडिंग डिसीज इज द रिस्क फैक्टर फॉर डेवलपमेंट ऑफ मैलिग्नेंसीज. तो पेशेंट को क्या हो रहा है, देयर इज अ क्रोनिक GERD दैट कैन लीड टू मेटाप्लेशिया, दैट कैन लीड टू चेंजेस इन एपिथेलिया, दैट कैन बी अ रिस्क फैक्टर फॉर कैंसर. ये मैलिग्नेंसी कराता है. यस, इट्स अ करेक्ट स्टेटमेंट. एंटायर लेंथ ऑफ इसोफेगस इज अफेक्टेड इक्वली. नो. अगर आप देखोगे लाइक इसोफेगस अपर 1/3 इज जनरली स्पेयर्ड. इट मेनली अफेक्ट डिस्टल, दिस एरिया में डिस्टल 1/3 में अफेक्ट करेगा, अपर 1/3 इज जनरली स्पेयर्ड. तो आंसर इज सी. A 64-year-old male known case of chronic kidney disease, CKD का पेशेंट है, present to nephrologist for follow-up. He complained of recent onset bone pain. Bone pain हो रहा है, wrist fracture है, following a fall from bed. So उसको समझो एक बार. So CKD patient when they develop bone change, इसको हम पहले बोलते थे renal osteodystrophy. It was previously called renal osteodystrophy. But now this term is removed. Now what we call this metabolic bone disease, MBD. It's a new term. So new term we have for osteodystrophy is metabolic bone disease. अब एक्सरे हुआ है, इसमें क्या दिख रहा है ऑन एवेल्युएशन. तो एक्सरे में अगर आप देखो यहाँ पर कुछ तो दिख रहा है, मैं अभी बताऊंगा क्या दिख रहा है. He was noticed to have low vitamin D. So किडनी CKD के पेशेंट में विटामिन डी कम होता है. हाइपोकैल्सीमिया, विटामिन डी कम है तो कैल्शियम भी कम है. हाइपरफॉस्फेटेमिया, फॉस्फेट बढ़ा हुआ है. व्हाट इज द मोस्ट लाइकली डायग्नोसिस. तो MBD ऑस्टियोडिस्ट्रॉफी ऑप्शन में नहीं है. अब क्या करें, देखते हैं आगे. चलो ओके, सो लेट्स सी ऑप्शन 1 by 1. सो अगर मैं बात करूं, पहले इसकी बात कर लेते हैं. बोन मेटास्टेसिस. देखो बोन मेटास्टेसिस होगी तो लॉजिक की बात है, यहाँ पर कैल्शियम बढ़ेगा ना कि कम होगा. सो दिस इज द हिंट. कोई भी MCQ में एक ना एक हिंट मिल जाती है. कमिंग टू मल्टीपल माइलोमा. अब मुझे बताओ मल्टीपल माइलोमा में क्या होता है, कैल्शियम. मल्टीपल माइलोमा में कैल्शियम बढ़ता है, तो कैल्शियम के बिहाफ पे ज़्यादा डायग्नोस बन गया. तो दीज टू आर नॉट द आंसर. पॉलीओस्टोटिक फाइब्रस डिस्प्लेशिया, इसको देखो. पॉलीओस्टोटिक फाइब्रस डिस्प्लेशिया में कैल्शियम और फॉस्फेट ये दोनों नॉर्मल रहते हैं. तो डायग्नोस रूल आउट करके क्या बचा, ओस्टाइटिस फाइब्रोसा सिस्टिका. अब इसको समझो एक बार. CKD के पेशेंट के अंदर क्या होता है, फ्रीक्वेंट फ्रैक्चर होता है, तो कई बार बोन्स के बीच में सिस्ट बन जाते हैं. यू कैन सी दिस एम्प्टी कैविटी हियर, सिस्ट बन जाते हैं. और जब इन सिस्ट में हेमोरेज होता है तो दीज सिस्ट आर हैविंग टेंडेंसी टू ब्लीड. सो व्हेनेवर देयर इज अ ब्लीडिंग इन दिस सिस्ट देयर विल बी लाइक ब्राउन डिस्कलरेशन ड्यू टू हेमोसिड्रिन. तो उसको हम बोलते हैं ब्राउन ट्यूमर. सो ओस्टाइटिस फाइब्रोसा सिस्टिका इज नथिंग. CKD के पेशेंट के अंदर बोन में सिस्ट बन जाती हैं और उसी को आगे जाके क्या हो जाता है, अगर ब्राउन कलर का पिगमेंट जमा हो जाता है तो उसको हम ब्राउन ट्यूमर बोलते हैं. सो आई डायग्नोसिस ओस्टाइटिस फाइब्रोसा सिस्टिका. एक्चुअली इट इज़ अ मैनिफेस्टेशन ऑफ MBD. ओस्टाइटिस फाइब्रोसा सिस्टिका ये मैंने CKD में पढ़ाया हुआ है, अगर आप देखोगे वहाँ ध्यान से. एंड व्हेन इट इज ब्राउन, इसी को क्या बोलते हैं, ब्राउन ट्यूमर. ब्राउन ट्यूमर. So this was our discussion. Okay, one more MCQ is there. A 27-year-old lady with primary infertility, young patient है, diagnosed with hypothyroidism. All of the following are true about investigation and management of this except. So we have two forms of hypothyroidism, means primary and secondary. So in primary, T3, T4 are low. So this will give a feedback to pituitary. तो pituitary क्या करेगा, TSH को बढ़ा देगा. Pituitary will increase TSH. इन सेकेंडरी फॉर्म TSH ही कम है, TSH कम है तो T3 T4 क्या होगा, इसको सिग्नल कम जाएंगे, सो T3 T4 विल बी लेस. This is for secondary. So primary means it's a problem in thyroid gland problem, and secondary means problem in the pituitary. तो पिट्यूटरी में क्या हो सकता है, पिट्यूटरी में पिट्यूटरी एपोप्लेक्सी, इट कुड बी शिहान सिंड्रोम, सिमॉन डिसीज और क्रैनी रेडिएशन. किस तरीके से पिट्यूटरी खराब हो गई. नाउ दे आर आस्किंग यू क्वेश्चन लाइक ऑल आर ट्रू एक्सेप्ट. अब देखो कोई भी पेशेंट आएगा अगर हाइपोथायराइडिज्म का, सो मोस्टली व्हाट वी सी प्राइमरी फॉर्म. So the first test and the best test that we use, first and best hormonal test is TSH, not T4. So T4 is not the test. तो ये तो मुझे सही लग रहा है आंसर. आगे देख लेते हैं. नॉर्मल TSH रूल्स आउट प्राइमरी हाइपोथायराइडिज्म. ये सही नहीं लग रहा मुझे, तो आगे देखते हैं. नॉर्मल TSH, सपोज किसी पेशेंट का TSH नॉर्मल है, ऐसा हो सकता है. अगर TSH नॉर्मल है तो इट विल रूल आउट हाइपोथायराइडिज्म, नो, राइट. TSH में कुछ ना कुछ चेंजेस तो आएंगे, लेकिन कई बार क्या होता है, कई बार आप देखते हो लाइक T3 T4 कैन बी नॉर्मल. तो दिस इज अ ट्रू स्टेटमेंट. तो नॉर्मल TSH अगर है तो प्राइमरी तो नहीं होगा. देखो प्राइमरी में पिट्यूटरी कुछ ना कुछ तो करेगी. फ्री T3 मेजरमेंट इज नॉट रिक्वायर्ड. अगेन देखो T3 T4 देयर इज मोर पेरिफेरल कन्वर्जन, so I can say free T3 measurement is not of any use. So generally we prefer to use TSH and free T4. ये भी true है. Low T4 and normal TSH. T4 कम है, TSH नॉर्मल है, इसका मतलब पिट्यूटरी कुछ नहीं कर रही. So again this could be a possibility, it could be true. So free T4 is not the screening test. Screening test is TSH. So this is, I can say, the answer for this question. So इस टाइप के क्वेश्चन भी एग्जाम में आते हैं. सो जस्ट रिमेंबर समथिंग लाइक फ्री T3 इज नॉट रिक्वायर्ड बिकॉज इन लेस देन 25% ऑफ पेशेंट यू कैन सी इट कैन बी ऑफ नॉर्मल वैल्यू ऑल्सो. T3 कैन बी नॉर्मल. तो इसलिए फ्री T4 इज नॉट, आई कैन से, स्क्रीनिंग टेस्ट. व्हाट वी हैव TSH एज द स्क्रीनिंग टेस्ट. So with this we have concluded. Thank you so much. Keep working hard. फिर अगले सीबॉट में मिलते हैं with more knowledge. Thank you so much. Bye bye.